Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect welcoming you all for today's webinar, TNFOG with 8 sister state societies. So let us start the webinar with Saraswati Vandana. Let me introduce the MOCs of today's webinar. Dr. Madhumita ma'am. Ma'am is the National Coordinator of Midlife Management Committee, FOXY. I welcome you, ma'am. And it's my privilege to introduce Dr. Priya Kannappan ma'am. Ma'am is the Senior Consultant at Dr. Mehta's Hospital, Chennai. I welcome you, ma'am. And it's my honor to introduce Dr. Radhika Gauri ma'am. Ma'am is the Specialist Consultant in OBG and Clinical Lead at ESIC Hospital, Tirunelveli. I welcome you, ma'am, and I hand over the session to MOC.
Dr. Radhika,
yes,
I'll take up. Yes, thank you. So can we have the CVs of all that? Today, I would welcome each and every one of you for the webinar on TNFOG with the 8 sister states. So it is our privilege to introduce Dr. Sambat Kumari Madam, past President for OXY and Vice President of the year 2022. And Madam is she is one of the candidate for the FOXY President elections in the August 2026. So over to you, Sambat Madam.
Yes. Thank you, Dr. Priya, Dr. Radhika, and Dr. Madhumita. And I welcome all the, as Dr. Priya told, I am contesting for FOXY President. This year, election time is here, August 1 to 10. I thank all the societies for nominating me. And please support and vote for me and make your members also to vote for me. Now I welcome the President and Secretaries of the 8 sister state societies. This is the webinar with every Tuesday it is conducted by Tamil Nadu Federation with the other states. I think we have completed Gujarat, MP, Haryana, Punjab, and this is the 5th place. See, I was traveling to Northeast last week. That time Dr. Avid Datta only told. Here there is 7 states, sister societies are there. Now another one is Tripura is also included and 8 sister state society. So I thought we will do it. So I welcome Nagon Obedient Society President Dr. Arupan, Secretary Dr. Bhaskar, Silchar Society President Dr. Devanjana and the Secretary Dr. Alaka, Shillong Society President Dr. Alok Dep and Nilot Parna Secretary and Impal Society President Dr. Rajkumari and Secretary Dr. Digil Singh and Kohima Society President Dr. Kevil and Secretary Dr. Kedichu, Gangtok Society President Dr. Ritunath and Secretary Dr. Hafizur Rahman, and Assam, the 7 places I went. There's 3 places only left, so I thought we can include them in the webinar. Barbita OBGN Society President Dr. Paresh and Secretary Dr. Surat, Tezpur Society President Dr. Utpal and Secretary Dr. Sunita, Aishwal Secretary President Dr. PC Lalram Hulna and Secretary Dr. Ziz Sangliena. If I have not pronounced correctly, please excuse me. I welcome our chief guest, Dr. Shailina, and our panel on case scenarios in endometriosis by Dr. Avi Sharkar and expert Dr. Priya Kannappan and the panelist Dr. Monisha, Dr. Radhika Gauri, Dr. Teresa, Dr. Momati, and Dr. Sonia. And MOCs are Meera Raghavan, Madhumita, Priya Kannappan, and Radhika. Thank you so much. Once again, I request all of you to vote for me. Now we'll go with the CV of Dr. Shailina Madam.
So Dr. Shailina Madam, she has done her MBBS from Varda 2001 and CMC Bello, she's done her DGO and she's a FICOG and she's been the immediate past president of the Shillong Obs and Gyne Society, East Zone Coordinator for Environment Health Committee FOXY of 2026, Chairperson of the FOXY East Zonal Conference with Yuva in 2025 and a contributor author in FOXY Focus plus on the AUB and faculty in various regional and national conferences. Madam, over to you for a few words of wisdom, ma'am.
Priya, we cannot forget the conference which she conducted in Shillong, VP conference, Shamal said. I still remember her green colored dress. All of them is red and she was with the green colored dress. Welcome, Dr. Shailina Madam. Please few words and bless the webinar.
Thank you so much, ma'am. First and foremost, I would like to say that I thank the Tamil Nadu Federation of Obs and Gynae in organizing this webinar, and most especially, I would like to thank Dr. Sampath Kumari for raising me up to this pedestal. I feel so honored and I'm so thankful to you for making me the chief guest of this wonderful seminar. And I wish you all the very best for your upcoming elections. You are a very able and a very knowledgeable person, and Foxy would be it would be an advantage to Foxy to have you as our president. And regarding endometriosis, endometriosis is a very common problem nowadays, much more now than before. And endometriosis is something that we face in our day-to-day practice. It is a very challenging disease, and it is good that you have put this webinar so that we'll delve in more detail in this, because it really cripples the patient's life with this disease. So thank you so much, ma'am, and I wish this webinar a very great success. Thank you very much, and I bring you greetings from Shillong.
Thank you, Dr. Shailina, for the new wonderful words, and we need your continuous support. Thank you, Shailina. If time permits, please be there for that talk and the webinar.
Thank you.
So can I invite Dr. Alaka, madam, and before we start with the session, can we have a few words of wisdom? Dr. Alaka Banerjee, madam, are you there?
Yes, ma'am. Good evening. Good evening, Sampath Kumari, madam.
Yes, good evening, Dr. Alaka. Welcome.
Yeah, we met in the NeosCon in Guwahati.
Yes,
and we are honored that you have included us in your seminar in this meeting. So definitely we all wish you all the best, and we'll see that our members also vote for you. All the best, ma'am.
Thank you, Dr. Tilaka. She is the secretary of the Silchar Society.
Yes.
Is there anyone?
Yes, ma'am. Dr. Nilotparna, madam. She is the secretary of Madam Dr. Nilotparna, madam.
Good evening, madam. Sampath Kumari, madam.
Good evening. Good evening. How are you?
It is very nice of you to include all the Northeast states in organizing this webinar. All the best for the elections. Our support from the Shillong Society will be with you, madam.
Thank you, madam. Dr. Nilotparna. Thanks for joining with us.
So there is one doctor name, I don't know, because they have not yet renamed. So
Dr. Kevil. Dr. Kevil. Yes, Dr. Kevil, you can. He is the Kohima Society president.
Yes, I'm here.
Yes, sir. Welcome, sir.
Hello, good evening, everyone.
Good evening, sir.
Thank you for organizing such a interesting topic, endometriosis. And it has been a pleasure for me to learn from the abled ones. And of course, we wish you all the best for your elections. As Dr. Shalnya has said, we will be blessed to have a very learned and a very experienced doctor as our FOXY president. Thank you.
Thank you, doctor. Thank you. He is the president of Kohima. Thank you for joining us, sir.
Thank you. Thank you.
If any one of them there, we can make him bless the webinar, and or we will go with the scientific. Dr. Impal, no one. Dr. Rajkumari is not there, I think.
No, ma'am.
Nago.
Only one person is not doctor. I'm not sure, like they have not renamed. Nobody else is there.
Okay, then we'll go with the scientific session.
Scientific
Yes,
session.
Priya.
So the first scientific session for today will be a talk on adolescent endometriosis. So it will be given by our legendary Madam Dr. Sambat Kumari. We know if you name about adolescent endometriosis or adolescents, she has been our chairperson for adolescent, of Foxy. So, like talking about that, she's the right person to give us a proper insight on this topic. Over to you, ma'am.
Thank you, Priya. Sakiti, can you project?
Yes, ma'am.
So good evening to all, and I thank all of the president and secretaries of 8 state sister societies for being here. And today, the endometriosis, as Madam was telling, it is the incidence is nowadays it is increasing. So we thought we do not know. Once it is an endometriosis, most of the time it is continuous. It will be there, but how to reduce the pain and how to manage? What is the cause? Whether they need the infertility or whether they are completed the family, that is very, very important. So once again, I request all of you to vote for me. Next slide. See, as all of us know, the adolescence is a period which is in between the childhood and the adulthood. The adolescence between the age of, it is from 10 to 19 years. They are neither children nor the adult. As per WHO, it is divided into 3 categories: early adolescence, middle adolescence, and late adolescence. That is the development of the secondary sexual characters, and in the middle adolescence, attracted by the opposite sex, and the late adolescents, they want an identity. So it is our duty to streamline the adolescence. Why the adolescents are important? Now the today's populations, 23% of the populations are adolescent. And India has the most maximum number of adolescent present country is India. The next slide. So that's the reason we have to streamline the adolescence. Regarding the menstrual history, the endometriosis, as all of us know about the HPO axis, that is hypothalamo pituitary ovarian axis. From the hypothalamus, hormones secrete and they act on the pituitary, the GnRH, and there it releases the FSH and LH, which acts on the ovary, producing the estrogen in the earlier phase and progesterone in the late phase, which act on the endometrium and produces the bleeding. When there is a pain during this bleeding, that is the tissues of the ovary, endometrium present in the ovary, we call it as the endometriosis. Previously, we thought it occurs only in the reproductive age group. Now it starts even in the adolescent endometriosis. What happens mainly when the patient complains of pain during menstruations, the seniors in the house, they tell it is nothing, it will be all right. Even the grandparents, they will tell when you get married and go for a normal delivery, it will be okay. But it is not like that. If the pain is not relieved by small analgesics like that, it has to be evaluated. It could be an adolescent endometriosis. So the relief of the pain during the menstruation is very, very important for the academic purpose and the general life or everything it is needed. The next slide. So 18-year-old girl comes with the pain during menstruation. She is having the periodic bloating and the constipation, diarrhea, attain menarche at 14 years. What could be the diagnosis? The diagnosis is most probably the dysmenorrhea. The dysmenorrhea can be the primary dysmenorrhea or the secondary dysmenorrhea. Primary dysmenorrhea without the pelvic pathology, and the secondary can be with the pelvic pathologies. So the next slide. Most of the time the endometriosis comes with the secondary dysmenorrhea. That secondary dysmenorrhea, the example is mainly the fibroid and the endometriosis. Commonly, the pain during menstruations, we have to think of the endometriosis. It is a benign condition only, but the endometrial spots will be present in the ovary. And sometimes the patient will be very, they may not be able to tolerate and they may not go to the school. So we have to elicit the history. If the girl is taking absence from the school every month, and from that we can find out that she is having some pain during the menstruations, that is endometriosis. That is the presence of endometrial gland and stroma outside of the normal locations. Next slide. So the endometriosis, what is the incident? Most of the time, the reproductive age, it is 6 to 10%. But in the adolescence, we don't have the perfect percentage because most of the time it is not reported. And even if it is reported, we have not diagnosed. Now, catch the endometriosis during the adolescence. It is important. Now we have the endometriosis awareness month. And when we go to the schools, we talk about the endometriosis awareness. What are all the symptoms will be there? Everything we are doing in our Tamil Nadu, from our society, we are doing lot of the adolescent program, and we talk about the nutrition, menstrual health, sexual health, and vaccination, teenage pregnancy. Among this, one of the topic is dysmenorrhea. There we will counsel the students to aware of the endometriosis. The next slide. If you identify it as earlier only, we can prevent. Because of this endometriosis, what can happen when they get married? They can have the infertility. In future, they can go for the PID. So there are many complications. This is the theories, the older theories, how the endometriosis happens from the Samson's theory, retrogression of the menstrual flow, and the coelomic metaplastic theory. These are all for the basic things which has to be known. The next slide. So the practical, the endometriosis, most of the time it is also present with the Mullerian anomalies. So the Mullerian anomalies, endometriosis with Mullerian anomalies also now the cases has been reported. When it is reported, there are some renal pathologies also present. So when we try to evaluate, we can find out the cause and whether any other system is involved. The next slide. So what are all the grading? The grading is, as we know, the stage 1, that is with the small implants will be present, and the implants of 6 to 15, more implants are present. 16 to 40 means if it is the deep implant, and more than 40 means it can be the wide spread will be present. So depending on the site, sometimes during the menstruation, they may be having the headache. Sometimes they may be having the pain during the urination. It can be this endometriosis. Nowadays, it has to be presented in all the parts of our body. Depending on the presentations, the complaints will be present. The next slide. Next slide. So as far as the adolescent is concerned, what will be the symptoms and the present? The cyclical pain is 63%, and acyclical pain will be 28%, and cyclical pain is 9%, and the gastrointestinal symptoms, sometimes they may be pain during that constipation will be the pain in the gastrointestinal, this mark will be present, that is 34%. Urinary symptoms will be present in 13%. Irregular menses, sometimes if it is not regular, it is also 9%, and the vaginal discharge in 6%. The next slide. So normally the patient will have pain during the menstruations. So that is the locations of the ovarian endometrioma is very, very common. Next slide. So this is how we are eliciting the pain during the menstruations. We are not going with the diagnosis directly to the laparoscope. So initially we evaluate the diary, the documenting when the bleeding is coming, when the pain is present, if the pain is associated with the bowel and bladder, and whether they have the missing of the school and social activities. They may not talk with their friends, and they will be ideally sitting in the house. These are all the indications for their interventions. So this calendar has to be maintained by the adolescents. So the diagnosis is mainly with the ultrasound. Now we have the 3D, 4D. With this and the Doppler, we can see whether it is only the endometriosis or the endometrioma, whether it has involved, what is the grading that can be done. If it is any doubt, we can go with the MRI. CT has only the limited roles, but it can be useful in the lung endometriosis, scar endometriosis. This marker, CA125, this may not be very helpful in case of endometriosis. It is elevated in most of the cases. Next slide. As I told, the CA125 is not specific, and it can be raised in any other conditions also. The normal value of the CA125 is 35 international units per ml. Next slide. Next slide. So the other biomarkers, these are all not practically done. Now they are doing the mRNA. Our Ramani madam is doing a PhD. She has done the PhD with the microRNA. So these are all for the PGs and the latest advancement. We have to know the other markers, interleukin, IL-6 and IL-8, tumor necrosis factor and the C-reactive protein, and the cancer antigens, CA19-9 and CA125, neutrophil lymphocyte ratio. These are all that other biomarkers which can be done. And the newer biomarker is urocorticoid, that is CRF, and it is 88% positive in endometriosis and 90% specific. And the folistatin, again 92% sensitivity and 96% specificity. For completion check, you have to know this. The main important thing is the ultrasound. This also we are not going to do the transvaginally, only the abdominal. It can be the unilateral or bilateral. Kissing ovaries may be present. It can be unilateral or multilateral. Septum may be thin or thick. And mobility is always restricted. And the site-specific tenderness will be present. Mural echogenic foci and low-level internal echoes and posterior acoustic enhancement. That is the ground glass appearance. Will be seen nodular wall thickening. This is the features of the endometriosis, and this can be confirmed with the MRI if needed. Next thing, because most of the time we don't go with the rectal examinations and the vaginal examinations for the adolescents. So MRI to confirm, we can go with the MRI, and with the MRI, we can have the exact diagnosis. Next slide. We can know the involvement of the bowel, bladder, and the ureter also. So the endometriotic lesions are typically clear or red and can be difficult to identify for gynecologists unfamiliar with the endometriosis in adolescents. But nowadays, the incidences are increasing. Most of us pick up the case in the earlier stage itself in the adolescents. If at all, if you go with the laparoscopic diagnostic, it is will be the powder burn lesions. Most of the time, surgical procedures or diagnostic lab is not needed for adolescent. Whenever you go trying to go for a laparoscopic procedure, the first surgery should be the good surgery, even for the adolescent or reproductive or whatever age. The next slide. So as far as the adolescence is concerned, only 3 points. One is the control of symptoms and prevention of the disease progression and the fertility issues. Because of the pain, she cannot go to the schools. So the symptoms has to be reduced. And the fertility in future, what will happen? So that has to be identified and it has to be corrected. So what are all the treatment? Mainly if the pain is present means we can go with some analgesics, anti-inflammatory. Now you have the Egolix tablets also that can be also given for the adolescents. Non-hormonal therapy, and then you go with the hormonal therapy. If at all needed, depending on the situations only, we have to go for the surgical excision. Destruction of any visual evidence of the endometriosis. The next slide. So what are all the non-hormonal therapies? This is if the pain is present means we go with the tricyclics, antidepressants. See, if the pain, mild pain means we go with the painkillers. And if it is not reduced, with the painkiller means we have to think it could be the endometriosis. Even if it is the endometriosis, if it is in the mild cases, it will be relieved with the analgesics itself, the mefenamic acid, ibuprofen, or naproxen. These are all used, but only side effect can be gastritis. Sometimes it can be given with any H2, like antacids or whatever Pandi we can add together with it. The next slide. So first tried with this non-hormonal treatment. And if the pain is not reduced and the girl is suffering too much, then you have identified this as endometriosis means we have to go for the that is the hormonal treatment. Most of the time for the adolescent girls, better to go only with the progesterones. The progesterones which can be used is medroxyprogesterone acetate or norethistran acetate. It can be 5 milligram or the 10 milligram. The main side effect most of the time progesterone has no side effects. When it is combined with estrogen only, some side effects can be present. So sometimes when with the progesterone, if the patient girl is having spotting, in that cases we have to go with the for third generation, the Dynogest combined with the estrogen, OC pills can be used. Danazol nowadays we are not using. Before 3 decades we have been using. Now the Danazol is not used. The Dynogest is the best drug for the adolescent. It is 2 milligram. It can be given even for 6 months. As I have seen some patients, they are taking even for a year. Let them be comfortable. First, we have to know whether she has to finish the exam or whether she has to get married and she wants the infertility problem. So depending on that, the Dynogest can be used. And nowadays, we are using the DMPA, Antara, which is available in the government setup also. That is depot medroxyprogesterone acetate. Previously, they thought it reduces the bone mineral density, but now there are theories which tells that DMPA is not going to interfere with BMD, so it can be used. This is the wide study with the Dynogest. Next slide. So the Dynogest is the safe and it can be combined with the OC pills also. So the progestin Dynogest is treatment for the endometriosis. Whatever may be the type of endometriosis for the adolescent, it can be used. Next slide. So the same thing which I have told, first you give the NSAID, then if at all needed, you go with this progesterones, and then the estrogen combined progesterones. Most of the time, the GnRH, we are not going to use this agonist for the adolescents. If at all used, it can be the history of amenorrhea. Depending on that, if it is not getting reduced, we go with the injections. Next slide. So this diagnostic and therapeutic laparoscopy, for the diagnostic procedure, we are not doing. Now we have the 3D and the 4D and the MRI. To diagnose endometriosis, the laparoscopy is not needed. Suppose the patient is not related with the medical management and she is having a severe pain, then in these cases, for the treatment purpose and the diagnosis purpose, laparoscopy can be used. Nowadays, the drug which is also used is the Elagolix, which I have told, that can be given 150 milligram OD or BD. Mostly they prescribe as BD, but for the adolescent girls, in my practice, I am giving 200 milligram OD. That itself, patient is having the pain relief. That also, it can be continued for 3 months or 6 months. The next slide. So the medical management, these are all the recommendations. So if the adolescent girls complains of pain, don't neglect. First, give some analgesic. And if it is not relieved, think of endometriosis and try to rule out with the ultrasound itself. And if needed, go with MRI. Main, you give that NSAIDs. If it is not getting relieved, go with the hormonal contraception, preferably the progestin alone. It can be given in the injection form also. If at all needed, if you are going with the GnRH agonist, again the HT add back has to be given. Suppose the girls are sexually active and they tell that we are sexually active. In that cases, even you can go with the levonorgestrel releasing intrauterine devices, that is the LNG IUS can be used. So these are all the guidelines which is followed for the adolescent. Recommendations. Next slide. So the Mullerian anomalies, as I mentioned earlier, the Mullerian anomalies is present up to there are studies which is 5 to 6%, in some cases 60%. In these cases, there may be an outflow obstructions. So if it is associated with Mullerian anomalies, most of the time it end up with the surgical procedures. Next slide. Next slide. So this is some case scenarios. A college girl, she is not bothered about the education. Next slide, ma. She wanted not bothered about the marriage in life. She wanted to finish her exam. So in that situation, first you go with the progesterone, and if it is not getting relieved, even you can go with the GnRH, because her profession is also important. After that, if she is getting released, go with the DMPA injections with the GnRH. If everything is reduced and the patient is comfortable, then go with the norethistron acetate, or nowadays you can go even with the Elagolix and postpone the treatment, because now she is bothered only about the profession. Now she is not bothered about the fertility. So the lifestyle should be good and she should be relieved from the pain. Next slide. So of all these non-hormonal or hormonal or Elagolix or DMPA or whatever treatment, the lifestyle is very, very important. I used to tell for the adolescents, 3 meals, 3 snacks. So always have a good fiber diet, avoid the fast food items, and 30 minutes exercise, anything, walking, cycling, dancing. If nothing is possible, they can do the sit-ups also. That is very important. And avoid the caffeine, vitamin B6, zinc, magnesium can be included. And the yoga, nowadays the yoga is very, very helpful. It feels the diversion of the mind, and the pain can also be reduced. The acupuncture, sometimes they are good with acupuncture, hot water bottle with cold compressions. So the take-home message is identify and diagnose the endometriosis in adolescents earlier, and try to treat them with analgesics or the hormonal treatment. Give the psychological support. If nothing is possible, finally only you have to think of the laparoscopy. The first surgery done should be a good surgery. So yeah, the multidisciplinary approach is always helpful to improve the quality of their lives. Thank you. So this is the final flow chart, which is very, whatever I have told, it has been mentioned in a single slide. So dear friends, please vote for me. See, from our as Tamil Nadu, especially after 37 years, we are contesting. Dr. Palaniyappan, the old professor, was the only one president. Please make all your members to vote. Last time the voting percentage was only 48%. Please make it to at least 70%. Thank you. Once again, I thank all the president and secretaries for joining us and the MOCs for giving this opportunity. Thank you. Thank you, Priya. We'll go with the panel. If any doubts, they can put in the chat box, we can answer. So now we go with the panel. I take pleasure in introducing Radhika Irkia, Dr. Avir Sarkar. I should thank Dr. Avir. Last week, I was traveling to 10 societies, starting from Durgapur, Dhanbad, Asansol, Bardwan. So all the 6 places, the Avir was traveling with me.
Okay, ma'am. Super.
Introduce him.
Okay. And Dr. Avir Sarkar is Assistant Professor, All India Institute of Medical Sciences, Kalyani. And he has done his MBBS from BHU and MD from PJ Chandigarh. He is East Zone Coordinator, Family Welfare Committee of FOXY between 2025 to 26. That's the current year. And he is Executive Member, Society of Meaningful Life Management between 2023 to 25. And also the Executive Member of Faridabad Menopause Society. And he is the organizing committee member of the Meaningful Life MTP Con between 2022 and HIAGE Con, that is 2023. And he has devised artificial intelligence aided contraception app for Indian couples in collaboration with IIT. He is very involved in TNFOG activities, and he, as ma'am said, he is also involved in Bodhana and other webinars.
He will be the future committee chair, Radhika.
Yes, ma'am.
He will be the future committee chair.
Yeah, super.
Thank
So we invite Dr. Priya
you so much for the warm introduction.
Yes.
Yes, Avir.
Okay. We invite Dr. Priya Kannappan, who is a senior consultant at Dr. Mehta's Hospital and GFC Fertility Center, Chennai. She is the executive committee member of OXY since 2021, and she's the co-chairperson of OXY Quiz and Clinical Research Committee. It was between 2023 to 25, and OXY Quiz Committee coordinator for Tamil Nadu, conducted many postgraduate quizzes, master trainer in FOXY HPV vaccination training program in 2024. Her key achievements are best outgoing student, and she's always supportive in TNFOG and important coordinator. And I invite Dr. Gomati ma'am, who is a consultant obstetrician gynecologist, currently assistant professor at Mada Medical College, Kundratur. She was formerly assistant professor in Government Stanley Medical College. She's a visiting consultant in Bevel, Sudarshan and KC hospitals. And she has done her PG in Stanley Medical College and UG in KMC. She's an OXY Life member, won Esther Gold Medal Award, special skills of in high-risk pregnancy, infertility, laparoscopy, in corpus. And I'm Dr. Radhika Gauri. And I invite Dr. Monisha M., who has done her undergraduation from Government Thoothukudi Medical College. And she has done her MS from Stanley Medical College between 2019 to 22, and DNB from DNB also. And she's currently working as assistant professor at Sri Muthukumaran Medical College and Research Institute. She has presented papers in national conferences and published articles in national and international journals. Welcome, Dr. Monisha. And we have Dr. Madhubala ma'am also, ma'am. Who is,
and we welcome Dr. Radhika Gauri, our MOC. She is also one panelist. Madhubala madam, you can also join.
And Teresa, Dr. Teresa from the ESIC Tirunelveli. She is a specialist consultant here. And we welcome Dr. Teresa and Dr. Madhubala ma'am, who is a
madam as an expert.
Yes.
With Priya. Yes. Welcome, Madhubala madam. Yes, Abir, you can start project.
Yes, I am sharing
Radhika
my screen.
And Teresa are working as assistant professor in Tirunelveli ESI.
Is the screen visible?
Yes.
Yes, it is visible.
I'll make it full screen. Yeah, so a very good evening, everybody, all the panelists, esteemed panelists with me. So we'll be quickly going through a few case scenarios as Sampath Kumari ma'am has already briefed about endometriosis, its pathophysiology, how it hampers the life of an adolescent girl. So we'll be starting with the first case, which will be a case of an adolescent girl. So she is too young for endometriosis to hamper her life. The clinical scenario is that a 17-year-old unmarried girl who has severe dysmenorrhea since her menarche. She has school absenteeism for 2 to 3 days in every cycle. The pain is not responding to NSAIDs or antispasmodics. No bowel or bladder symptoms. Transabdominal ultrasound was done, which was suggestive of normal pelvis, and no sexual activity till now. Now, the mother is very much concerned. Can this just be a normal period pain or it is something else? So, my question to any of the panelists can take up: when should endometriosis be suspected in adolescents? Can a normal ultrasound rule out the disease? Should empirical hormonal treatment be started or not? And when laparoscopy is justified in such young girl? And how to counsel the parents regarding future fertility? Anyone can take up.
Actually, I'm Dr. Gomati.
Yes, ma'am.
Since she is a young adolescent girl who complains of periodical cyclical pain only during cycle, first of all, she might be a case of primary dysmenorrhea, but that primary dysmenorrhea will not have any organic pathology or it will be relieved by medications. And it will not be progressive or persistent. So in this case, school absenteeism for 2 to 3 days every cycle and pain not responding to the NSAIDs and antispasmodic might clearly say that she might be a case of endometriosis unless and otherwise ruled out. So she should be strongly suspected. So we can't just rule out that this is a normal period pain. She might be a case of secondary dysmenorrhea. And ultrasound will not be able to pick up this early adolescent endometriosis because the vesicles will be like a clear fluid with a pale white, yellowish or pink in color, and the early disease will be superficial peritoneal disease. So if in that case, the ultrasound will be particularly very normal. That too, ultrasound abdomen, transabdominally, if we see, that will be giving a normal pelvis appearance only. So the ultrasound will definitely not rule out this as an endometriosis. And so she should be suspected as a case of endometriosis. And we can have one more clue that any history of neonatal bleed, or whether a detailed ultrasound with an MRI can give a clue to a Mullerian abnormalities, any obstructive Mullerian thing. Oral family history of endometriosis, we can just probe in such case. That will be helpful for us to guide in treatment. But anyway, the laparoscopy is not justified at all.
Yes,
So
and how
we
will
have
you
to
counsel the parents, ma'am? The mother is very anxious.
Yeah, mother will definitely will be anxious. So first line management is always NSAIDs. So because we don't want to give on any other medications, if NSAIDs are not playing a role, as madam told, yoga, lifestyle modifications and pelvic yoga, hot fermentation. Other than that, if you at all hormonal treatments, progesterones will be the great thing. Or oral contraceptive pills will be playing a role. Future fertility will not be affected. We can't say, but we have to reassure the patient as with this, since scan is normal, everything is normal. We should just give them a reassurance that future fertility will be normal.
1 minute, Dr. Avitsan.
Yes, ma'am. Very rightly said that we can. Yes.
Yeah, but if there is a large cyst, then
Yes, ma'am.
obviously,
Continue, ma'am.
yeah, then obviously then there is a role for laparoscopy, and in which case we can, more than 8 centimeter cyst, and if there is pain, then we can obviously we can counsel her, and we can do a laparoscopy at that time, and we can do a cyst decompression as well, and cystectomy can be done. But in this case, we have to counsel the parents also that there is due to the compression of the ovary, we can have reduced the AMH. Future also, she can develop, problems with fertility. So, in those cases, we can, it is justified. And we can continue with progesterones after the laparoscopy if she has a cyst, large cyst.
So can I add to that, ma'am?
Yes, ma'am.
Yes, the basic problem is the patient comes to us as adolescent. But the only thing is nowadays, we have all your dink and dinkies there. Double income, no, no commitment, and your double income, no pregnancy yet or no marriage yet. So that is what your young girls are like there. I had a patient who had endometriosis. They came to me for counseling, and the patient said, at least by the age of 30, I don't want to get married. So these, at least they should be highlighted. Their ovarian reserve will go down with the age, irrespective of the mode of treatment. Without any surgery, also their ovarian reserve will go down. This should be like at least given an information. We need not scare them saying that you're not going to have future fertility at all. You're going to be infertile. We need not do that. But at least a little bit that it has an impact should be told to the nowadays generation, because they cannot come back to us at 35 and 40 and ask us, can I get pregnant now? So, I think most of the people who are doing fertility will agree endometriosis and 35 years itself, it is nearing, like the reserve becomes very poor. We don't get fertility that well. So at least we should tell them not to postpone it too much for the career's sake. So that is one. And there is a role of empirical hormone, which most of the guidelines are supporting, even if your scans are normal. So there is a role. And even if it is an unexplained dysmenorrhea, unexplained reason, still they say you can put them on ossiples, progesterone alone. Instead of that, you can go with an ossiples as well. So I think that we are justified. And as madam has told, laparoscopy is only for large cyst or very much great pain, because one laparoscopy is what we are allowed to do now. So you cannot be doing repeated surgery as of now. So for a young girl, adolescent, it is a dilemma. We have to do that.
Yes, very rightly said. Even if the ultrasound doesn't pick up any lesions, then also we have to suspect endometriosis, and empirically we can start with hormones. So the second case is a case of infertility with endometrioma. So a 30-year-old nulliparous woman who has primary infertility for 4 years, mild dysmenorrhea, ultrasound shows unilateral left ovarian endometrioma measuring 5.5 centimeters. Her AMH is normal, around 1.5 nanograms per ml. Husband semen analysis is normal. Tubes are patent, luckily, in HSG. She wants pregnancy as early as possible. So my question to all the panelists, surgery first or proceed directly with IVF? What do you think? Opinions may vary. We'll just discuss over this discussion. Does cystectomy improve the fertility according to you? What is the effect of surgery on ovarian reserve? Should you go for oocyte or embryo freezing? Should it be discussed? And what is the endometrioma size threshold that you consider for an intervention? Yes, anyone can take it up.
Sir, we can directly proceed directly to the IVF rather than doing a surgery first. That is what the guideline says currently.
Yes.
Prior to IVF procedure, surgery is not routinely recommended. If the patient has persistent pain, significant pain, which is affecting her quality of life so much, and but after that only the fertility part comes, we can pick the surgery first. But if at all she is trying to conceive immediately, go for the procedure first. And if surgery is being performed, cystectomy is best rather than doing just a drainage and a fulguration or ablation surgery. And the effect on surgery on ovarian reserve, already her AMH is low normal, like 1.5. So the surgery on the ovary will affect even more the ovarian reserve.
Yes. And should you do you discuss regarding oocyte preservation?
Yes, sir. The fertility preservation must be explained to the patient. If she requires surgery for significant pain, we can go for the preservation and then do the surgery. And endometrioma size threshold is not the criteria right now, according to Esri. Only based on the symptoms, we do the surgery, and it should be individualized.
Yes,
We should
very rightly
counsel.
said. Yes, very rightly said. If the endometrioma is so large that the ovum pickup is not possible, it is then we go for a surgery followed by an ovum pickup. Otherwise, we directly nowadays recommend to go for an IVF rather than going for surgery again and again, as used to be earlier. So the third case is a patient, 32-year-old woman with severe chronic pelvic pain for 5 years. She is having deep dyspareunia and significant impairment in quality of life. Previous laparoscopy was done elsewhere and there was minimal superficial lesion, stage 1, and she underwent ablation. But she is telling that after ablation also the pain is persisting, and doctor says that the lesion is very mild, so you need not to care. Now, in this case, the patient comes to you. Now, my question is, why does pain severity not correlate with the stage or size of the lesion? Number two, central sensitization. Is it a real entity or overused term? What is the role of repeat surgery? What do you think? And what is the role of multidisciplinary pain management and psychological support of these patients?
Yes, actually, the stage will not correlate with pain. Pain stage and disease stage will not correlate, because even stage 1 and can have severe pain because of the neuroangiogenesis. Even the tiny superficial small lesions can contain stimulated nerve fibers that can release multiple inflammatory mediators, and they become pain sensitive. As well as they will have some peripheral sensitizations because of prostaglandins release or a cytokine release or their nociceptor activation. So many factors plays a role. Even the patient will be very hypersensitive. Their central sensitization, their setup will be like that. So pain will be disproportionate to the surgical finding as well as the ultrasound finding, and the patient will complain of pain. They might have other pain also, chronic pelvic pain of some other because they will keep their vaginismus tight, so their muscles will be very tight. So there can be so many reasons for pain. So we can't say it is a overused term. There is no role of repeat surgery, because already the as per the guidelines, repeat surgery has proven no role. But the multidisciplinary pain management will be of good support with psychological support.
Yes, ma'am. Very rightly said that pain is not proportionate to the size of the lesion. This is what we should remember. Even if the size of the lesion is very less, the patient demands good care, good individualized care, and hormonal support should be given. The fourth case is a case of DIE, that is deep infiltrating endometriosis. A 35-year-old woman with severe dysmenorrhea, deep dyspareunia, cyclical painful defecation, constipation during menstruation, MRI pelvis suggestive of rectosigmoid deep infiltrating endometriosis. What do you think? Is surgery mandatory, or you go for medical management? What is the need for colorectal surgeon in the team when you do such a surgery? What do you think is the role of segmental bowel resection and IVF before surgery or surgery before IVF if this patient plans pregnancy?
I think we can.
Yes, ma'am. You can share your views. There's nothing right and wrong in it.
Yes. So, we can do oocyte preservation and then go for a surgery or embryo,
But sometimes in these deep infiltrating endometriosis, sometimes medical management also works.
Yeah,
like going for such an extensive surgery, it is better to go for a leuprolide injection. 3 to 6 months leuprolide.
Yeah.
Nowadays, elagolix is coming. So
Yeah.
these are patients prefer that better, I think, rather than going for rectal shaving and all those things.
Yeah, we can freeze the embryos and then give the loop, right? And then do the IVF.
It again
Yes,
depends
yes.
upon the expertise of the surgeon as well. So
Yes.
if you are an expert, you can go with the surgery. And if your patient is willing to, go with the bowel resection, if at all there is a bowel injury. See, for any time you go in for a DIE endometriosis, you have to get your, segmental resection or even a colostomy consent and, your ureteric stenting or even a ureteric implant can be there. You just have to take out the nodule and then go in for ureteric reimplantation. So if it depends upon the counseling and what your patient wants. So if your patient is agreeing to those things, it is a high risk surgery. We have to explain that. And there is a role of medical, but most of the time we see that medical will not work that well in a DIE compared to a surgical management. You're taking the nodule because it is not a more of pelvic mass. It is more of extra pelvic, more of bubble and other things. It may or may not respond to the hormones. And most of the time, most of the drugs would have been tried by
Muted.
You are muted, ma'am. You got muted.
it comes as a second opinion patient to you where already most of the drugs would have been tried, mostly many cycles of ocipals, maybe a few months of Marina, maybe may or may not be with elagolix and other things. So I think most of the time they come back to you for pain. And these patients, for them the more concern will be for a complete cure with pain rather than fertility. Most of the time when they go into this kind of a situation, they'll be get everything done. And we have had patients who have planned put a Marina inside, and then we said okay, we'll go ahead with IVF. They come back and tell you no doctor, now the pain is much better, just leave me alone, I don't want any pregnancy at all. So that kind of pain, and that will be their mentality. So it is about counseling, it is about what the patient wants, and then we take a call on that.
Yes, very rightly said. Now, the fifth case is a 33-year-old woman with previous laparoscopic cystectomy for endometriosis. She presents with recurrent 6 centimeter ovarian endometrioma to you, and AMH is now low, 0.9 nanograms per ml, with persistent pelvic pain. She wishes a conception. So, should repeat surgery be done, or should it be avoided, or you go for IVF directly? What is the role of fertility preservation, pain management strategies, and how to counsel regarding recurrence? Anybody can
Since
take
she
it
is
up.
having, yes, sir, HAMH is only 0.9 and it is a case of recurrent ovarian endometriosis. She is having persistent pelvic pain. So, should repeat surgery is needed, means we can avoid if possible. But if if we are going directly for an IVF, the clots might interfere with IVF access and for follicle retrieval, or if it is rapid size growth, so we can remove. Current guidelines generally discourage routine surgeries, so solely to improve fertility. But unless and otherwise, it is interference for us or rapidly growing. So IVF directly is often preferred, so that because of age 33 with the declining ovarian reserve, obviously the staging of endometriosis as well as the repeat surgery is definitely going to cause further low AMH. So it's better to go for IVF.
See, the guidelines here, it is telling us the only, reason for repeat surgery is the pain. So you have to assess the pain score of the patient. And if the pain is so unbearable, that is the only indication where we suggest for the repeat, a repeat surgery for this patient. And another thing in endometriosis, we go with the endometriosis fertility index. We try to categorize these patients based on that. And if your score is quite poor, then we try to go for IVF for the case as first preference. And if suppose if it is a little better, then we can even go for surgery. So that is how for a fertility patient, we do it but definitely we don't try to go for recurrent surgery unless the pain score is very high. And even if planned, we can try one cycle of IVF, get the oocytes, get it retrieved, stored, and then also you can consider to go for surgery. So that is what, if you're thinking of fertility preservation, because anyway this one, and whenever we consider a fertility preservation surgery, it means how do we peel the cyst. So that is what you're meaning, whether you charge it or whether you go and put your electrocauteries near your hilum, and those things should be taken into consideration whenever we consider a surgery for the endometriosis patient. So I think that is what you're meaning by fertility preservation, right?
Yes, yes.
Yes.
Very rightly.
And pain management is obviously NSAIDs and progestins with the hormonal pills. And how to for counsel regarding recurrence, 100% we have to tell them it is a chronic recurrent disease. A surgery can reduce symptoms, so it will not cure the disease. So she might get again recurrent. So before that, she can complete the family.
Yes. So the last case for the day is a case of perimenopausal woman. She is 46-year-old multiparous with chronic pelvic pain, including dysmenorrhea, with increasing dysmenorrhea. Ultrasound is showing a 7 centimeter complex ovarian cyst with mildly elevated CA125. Her family is complete, 46 years old. So endometrioma versus malignancy, how to differentiate? Once the CA125 is raised, how do we differentiate? Is there any role of MRI or IOTA models to differentiate between benign and malignant masses of the ovary? Conservative management versus definitive surgery at perimenopausal age. Risk of malignant transformation, and should ovaries always be removed, or we can go for cystectomy at 46 years also.
Nice.
So there is a role for, I think, surgery here and definitive surgery. And there is a risk of malignant transformation also. But not in all cases, but we have seen 2 or 3 cases where we have had malignant transformation also. So we have to counsel the patient, and because she's nearing perimenopause and if the pain is severe, it's best to take her for a hysterectomy. But we have to anticipate additions, and preoperative stenting also could be done, and better to do with the proper precautions.
Yeah, see, at perimenopause, we will not try to go for any conservative surgery, first point. Second point, with all the additions, whatever you give a free margin, whether you give it or not, definitely it is going to form again. And second time, whoever is going to operate is going to have much difficulty. So you can send it to the person whom you don't like and then tell them, okay, come on, go to the next person there. So that is how, people say, if you want to refer an endometriosis, give a recurrent endometriosis to the person you don't like. So it's better that we complete the surgery. That is for one sure. Second thing is you can have, concurrent endometrial cancers. We have encountered cancers in these kind of women. And CA125 is not very predictive in these women. Sometimes you can have a CA125 of 2000 level and it can still be a benign endometriosis. And sometimes it is only mildly elevated and you can have a malignancy sitting on there. So if you have a facility of frozen section, I mean, if at all, if it's a younger woman where you're thinking of fertility preservation and you're thinking of a complex mass, see, usually your endometriosis will have a ground glass appearance, typical endometrioma appearance. Then we are we never find endometrial cancer in that kind of patients. But if it is a complex cyst, you should always keep in your back of your mind that malignancy should be there. Counsel the patient for complete surgery where you take out the, I will prefer at 46 complete, removal of both the ovaries along with the uterus. And then, what people don't understand about frozen is whatever we give them a frozen of small sample, they tell you it is very inconclusive. We are not able to tell you clearly. It may be benign, but we are not sure whether it's malignant or not. So anyway, you wait for an hour or 2 for frozen and then come back with a report that I am not very sure. Please wait for the histopathology. So if it is a 46 year, I think you go ahead and do the entire organ is what we counsel the patient.
Yes, very rightly said. So we had in this panel discussion very knowledgeable panelists who had given their inputs very nicely. So with that, we come to an end of today's panel discussion.
Wait 1 minute.
Yes,
You asked Dr. Madhubala madam for final opinion. Dr. Madhubala madam,
yes.
are you there?
Madhubala madam, please kindly give your expert opinion. We had cases from since adolescent to perimenopause, various different kinds of cases. So Madhubala ma'am, please give your inputs.
I'm not seeing madam in our other.
Okay, Avir, you proceed. Avir, you complete.
Madam, so Madhubala madam is not there.
Yes.
Okay.
Ma'am?
Okay, so we
Dr.
had
Alaka ma'am is with us. So should we ask Dr. Alaka ma'am to give her?
Yes, ma'am. Alaka ma'am, you can give your inputs.
Yeah, it was a very nice and informative panel discussion. Am I audible?
Yes, ma'am. Yes, Alaka, ma'am. Yes.
Madhumala madam is
Okay.
joining, ma'am. 1
So
minute.
it was really a very informative panel discussion. I really agree with all of you that in endometriosis, pain is the most problematic thing. So we have to tackle the pain first. And for fertility, IVF is the best option. So endometrioma does not affect the fertility. If you have the chance of ovum pickup, go for ovum pickup and do an IVF. But if this is obstructing the ovum pickup or the endometrioma is causing a lot of pain, then maybe we have to go for surgery. But
Hello.
IVF should be the first option if patient is desiring fertility. And for the postmenopausal, definitive removal of everything, which I'd also suggest. So it was a very nice discussion. Thank you.
Yeah, ma'am. Thank you.
Joining actually.
Thank you, Dr. Alaka.
I would request.
Dr. KV sir is also
I
there.
would- yes, yes. I
Priya.
would request others also to give your opinion. Kevil sir, you can give your opinion regarding the panel, the cases which we had.
Yeah.
Dr. Kevil sir? I'm not sure. Dr. Teresa ma'am, are you there?
Yes, yes, yes.
Yeah, Madhumala ma'am is there.
Depends upon the age and also the counseling need to be done prior to the surgery. Depends upon the patient wish also. If they don't want the baby, even though they are, we had one patient of 35-year-old, but she had the terrible pain. Radhika madam and we counsel the patient and then injection leuprolide was given for 1 year and then we have done the hysterectomy. She doesn't want the baby.
Yes, ma'am.
Only.
We all agree
That much
that,
pain she was
after some time when
having.
pain is there, I had a
Stage four.
patient, after repeated surgery, she wanted only hysterectomy. I even counseled her, let us get, like one pregnancy and then we can go ahead with hysterectomy. She said, no, get it out. It is enough. I had enough of pain, so no more anything surgeries. So that is their
After
mentality, madam.
she was thanking very much for doing that surgery. So
Yes.
happy for that.
Thank you, ma'am. Madhubala, madam, your inputs, ma'am.
Inputs and what, Priya? Sorry, I was in an
Sorry,
emergency.
madam. We had a panel discussion, madam, on endometriosis. We had a series of cases starting from adolescent, then we had fertility patient, then chronic pelvic pain, and finally we had a perimenopausal 46-year-old who had endometrioma with the complex mass. So can you just tell us your experience on the patients of endometriosis? So something special, some take-home point for all of us, ma'am.
No, endometriotic patients, adolescent, of course, we don't touch them. We treat them medically. And when they are wishing for fertility and if their AMH is normal, like above 2 or 3, then if after medical management, if the patient is not getting normal or still persistent, pain is persistent, I'll go for endometriotic cystectomy. Then my post-operative treatment would be injection Zoladex. Zoladex monthly once for 3 months, for which I've had enough success.
Wonderful.
So Zoladex is nothing but goserelin injection. It's not leuprolide. So goserelin has enough success after because patient automatically they conceive most of the times. And if the AMH is low, we tell them immediately to go for IVF.
IVF.
So even after goserelin, the success rates are good. I don't know what discussions you people had, but I'm sorry, I was about to join and I had an emergency. I thought I should go.
No issues.
Was there a goserelin in your discussion?
No, ma'am, no.
Goserelin is supposed to give because somehow I picked up very earlier, around 20 years back, I started giving goserelin. Some papers and research articles I went through. And after that, it was only not looking back, only with goserelin. And the success rates, we have to have that much of data we have with endometriotic cystectomy with Zoladex.
Nice. Good take home message.
Dr. Kevil sir is joined, ma'am.
Yes. Sorry, I was a little bit engaged and I could hear my name, but so sorry for that.
Yes, sir.
I have been listening to the panelist, and it's a wonderful experience by all the panelists to give their very thoughtful experience on the endometriosis. And it has come to my notice that, yes, of course, I agree with all of you, but on one thing or another thing, this our professor, one of my professor, Dr. B.N. Chakravarti, he says that endometriosis as such should be also investigated on the line of PCOS, and that's always strikes me. So PCOS, as we know, it has been recently named as polyendocrine metabolic or whatever
Ovarian,
syndrome.
ovarian syndrome,
But of
PMOS.
course, some people are of the thing that let it be PCOS, polyendocrine ovarian syndrome kind of thing. So I agree with all of these things. Apart from that, always what I've been noticing is in many of the cases, in 50 to 60% of the cases, I always see endometriosis in conjunction with PCOS. So
Hyperestrogenic.
yes, so this further take me into rather unconventional methods of assessment, and I have already gathered some few data about all these things like PCOS and endometriosis. Rather, when we investigate, it always have a increased HbA1c. At the same time, they have a deranged HOMA-IR. So the the standards for HOMA-IR is 1% is cutoff point for normal, but and more than 1.9 is considered as insulin resistance. But I see that HOMA-IR abnormality even starts by 0.5%, 0.5. Then HbA1c is tricky. Why it is tricky? Because in 4 months' time, a woman has 4 cycles. So when she has 4 cycles, it may be sometimes heavy menses, sometimes less menses. So depending on all these things, the HbA1c may have a variation of zero point 0.2 to 0.5%. So it may show give a normal HbA1c of 5.2, 5.3, but in actual practice, it may be ranging in a pre-diabetic range, like 5.6, 5.7. And this pre-diabetic range, when you have a HOMA-IR test, it is always deranged. So basing on these two, I have a trajectory, I have a hypothesis rather. So I'm investigating into it rather that probably the insulin resistance and the pre-diabetic condition has given some impetus for even inflammatory response in conjunction with estrogen. So when estrogen and insulin comes together, it creates a explosive kind of a fertilizer for even see implantation growths here and there. So probably like these things are under my hypothesis, but I'm still doing some studies and still collecting some few cases. So probably by the time they
Lovely,
reach
sir.
100, 150, 200, like, I'll give a proper analysis and release the my study also.
It will be
My
very nice to learn once you've done a study. You just update us, sir. It will be
yes, my
nice to hear itself.
thank you. My this one suggestion is each and every one of us do a different study in your own territory also. Do some HbA1c and HOMA-IR also and investigate it on your own terrain and see come to a consensus whether this one is also bearing some truth in it or not.
Sure, sir.
rather
Definitely.
than rather than like what we call following the rabbit hole and getting lost into the rabbit hole, see that the outcroppings and the origin of it and have a kind of a consensus, original study by every centers. That's what my suggestion is. Thank you.
We can do
I
it.
took such a long time also.
It's a good suggestion, sir. Good suggestion. Yeah.
Thank you.
We will do it.
Oh, please.
Thank you. Nice opinion. Yes,
Thank you.
Abir, you can give the concluding marks.
Yes, ma'am. So it was a very good panel discussion. We had cases spanning from the adolescence to the perimenopause, and all the panelists gave their inputs very nicely. It was a lively discussion. Everyone said what they do in their day-to-day practice and what evidence says. So this is all. Over to the MOCs. They can take over and conclude the session today.
Thank you. Thank
Thank
you,
you.
Dr. Rakesh. So it was such a wonderful discussion. So thank you everyone for joining today. It is my pleasure to thank all the presidents and secretaries of all our 8 sister states, Dr. Paresh Kalita and Dr. Surat, President and Secretary of Barpita Obsangine Society, Dr. Arup Jyoti and Dr. Bhaskar Sharma, Nagon Obsangine Society, Dr. Devanjana and Dr. Alaka, Silchar Obsangine Society, Dr. Utpal and Dr. Sunita Gogai at Tesbur Obsangine Society, Dr. Rajkumari and Dr. Dijal Singh at Impan Obsangine Society, and Dr. Alok Deb and Dr. Nilot Parna of Shillong Obsangine Society, and Dr. Lal Ram Luna and Dr. Zirzang Lia of Aizawl Obsangine
Aizawl.
Society. Okay. And Dr. Kevil and Dr. Teja Vino of Kohima Obsangine Society, and Dr. Ritu and Dr. Hafizur of Gangtok Obsangine Society, and Dr. Bapatia and Dr. Arindam of Agartala Obsangine Society. Kindly excuse us for the mispronunciation. Really sorry for that. We are trying our hard to pronounce it correctly. And I would like to thank
Yeah,
Dr.
but chief guest.
Shalini. Yes, ma'am. Dr. Shalinia, madam, was our chief guest. So thank you, madam. Thank you. And Dr. Sambat Kumari, madam, who's been the speaker for the first session. And Dr. Avir Sarkar, a wonderful moderating session on different case scenarios of endometriosis. And thank you to all my panelists, Dr. Monisha, Dr. Sonia, Dr. Gomati, Dr. Radhika Gauri, Dr. Teresa. And thank you to my co-MOC, Dr. Radhika Gauri, on that. And thank you, Madhubala, madam, for joining us and giving her insights. So thank you each and
I would
every
like
one of
to
you.
add one thing. I would like to appeal to all the presidents and secretaries to kindly make everyone vote, because the only way to get maximum votes is to make the people who are not voting to vote.
Yes. And
Because only 48% people have voted last year. So 52% are still remaining. Even if we take votes from them, we win anyhow.
True. Thank you, Dr. Ravi. That was such a wonderful suggestion. And I would request everyone to remember Dr. Sambat Kumari, madam. She's one of our election candidate for the year to 2026. August 1 to 10 is our election date. Kindly remember to vote for the president's election. So thank you each and every one of you for joining today.
Thank you, Priya. Thank you to all of you. Good night.
Thanks, madam.
Thank you.